Good morning, good afternoon, and good evening. Welcome back to this lecture on Parkinson's disease. Today I will be discussing the diagnostic criteria for Parkinson's. So, the last video we discussed the common symptoms such as tremors, rigidity, bradykinesia, postural instability, gait affectations, and so on and so forth. Now we will be putting that information to use. How do we actually know that this patient has Parkinson's? So here is the diagnostic criteria for it. Firstly, the patient should have at least two of the three most prominent or staple features of Parkinson's: tremor, rigidity, or bradykinesia. So they could have tremor and bradykinesia, they could have rigidity and bradykinesia, or they could have all three. The minimum is two. Next, there should be a presence of at least two of the following. So aside from these symptoms, they should have two of these. So it should be asymmetrical. Signs or the symptoms are asymmetrical. The onset is asymmetrical, and when um, they have received levodopa as a medication, it actually helped with their symptoms. And lastly, other features is that there is actually disease progression, meaning the disease got worse over time, or in the history it got worse over time. And also there you have differentiated from other diagnoses. So that's why later on I'm going to be discussing differentials. Here is a table from Merritt's Book of Neurology. So this is the modified Hoehn and Yahr staging scale for Parkinson's disease. So this is basically just a scale from 0 to 5. And 5 is the worst one, and 0 is the best one. So as I've mentioned in the earliest parts of this lecture, is that usually symptoms for Parkinson's, they present very late. So once symptoms have already presented, at least 60% of dopaminergic neurons have already been lost. And so we have stage 1. There's no signs of the disease, but there's could be an affectation that we just can't see. But for now, there's no sign. Stage that's stage 0. Sorry, can't read. Stage 1 is you have asymmetrical affectation. Stage 1.5 or 1.5, there's unilateral, but there's also axial involvement, meaning gait, postural instability. Stage 2 is it when it becomes bilateral, but there is no impairment of the balance. So that's how you differentiate these two. 1.5 has axial involvement, 2 doesn't. I mean, they could balance. 2.5, there is a mild bilateral disease, normal pull test, which is the loss of postural reflexes, and there's still recovery to avoid falling. So that could be the fascinating gait, freezing gait or something. And stage 3 is mild to moderate bilateral, so it's getting worse here. And this is where you can see postural instability. So in 2.5, usually they would have they they would be affected by the pull, but they would still be able to recover. But in stage 3, they are not able to recover. So they're still physically independent, but um there is some postural instabilities. In stage 4, you have severe disability. So they are unable to walk, they are unable to stand up without assistance, and these patients usually have equipment with them like canes, wheelchairs already, but they're still able to ambulate without the wheelchair. Stage 5 is when you get wheelchair bound or bedridden. So this is really when you've lost, mostly in 4 to 5 is when you've lost your activities of daily living. So the patient is unable to do anything independently anymore. So, or they can, but there's a high risk of injury and pain. So again, stage 0 is from okay to not okay. So the differential diagnosis for Parkinson's. Um, Usually, if you want to differentiate Parkinson's from other conditions, the early symptoms are asymmetric, often asymmetric. And there is again resting tremor, cogwheel rigidity can be supportive of the diagnosis because those are the cardinal features. And again, if you provide medications like levodopa, there is a positive response. Again, as I've mentioned in the previous lectures, that essential tremor is different differentiate from Parkinson's disease, as essential tremors have kinetic tremors, not resting. Parkinson's has the resting. So again, essential, kinetic, Parkinson's, resting. So here we have the Parkinson plus syndrome. The Parkinson plus syndromes, they're like they mimic Parkinson's, but they have added symptoms. For example, corticobasal degeneration has an alien limb, so it's similar to hemiballismus, where your arms just like suddenly move on its own or fling upwards. As for dementia, yes, we've seen Lewy bodies. Hopefully, you understand what Lewy bodies are. If you haven't, you could read more on that, or you could watch the previous video again. So this is just dementia, but the why it could mimic Parkinson's is because it has affectation of the Lewy bodies. Basically, again, Lewy bodies are not a sole indication of Parkinson's, right? In dementia, you usually have vivid hallucinations, and your alertness fluctuates easily. That's why it's important for dementia patients to have a caregiver present or a family member present, because they do not have the same level of coherence in their thought processes. And here we have the shy dragger syndrome, which is the older term for multiple system atrophy, MSA. So usually in the shy dragger syndrome, this is characterized by orthostatic hypotension, meaning when you try to stand up from a supine position, you suddenly get dizzy or lightheaded, and you have bladder syndromes, maybe a distended bladder, or you urinate very frequently, or you don't urinate at all. So here we have heredodegenerative diseases. So from the term heredodegenerative, it's just a combination of hereditary and degenerative. So usually the most prominent ones are Huntington's disease and Wilson's disease to be compared to Parkinson's. Because first, Huntington's is an affectation of the basal ganglia, and it does present with movement disorders, but Huntington is a hyperkinetic disorder, so there is an increased amount of movement. Chorea, as the term suggests, is similar to choreo, right? So with chorea, usually the patient has like movements that are similar to dancing, that are involuntary. So it's hyperkinetic. And usually it's related with psychiatric and neurological diseases. In Huntington's, there is Huntington buildup. That's why it's called Huntington's. Or actually, I'm not sure, but I feel like that's right. Next, we have Wilson's disease. So this is just an affectation of your internal organs. So this their generation of copper accumulation. So there could be too much copper, and the liver is unable to um, delegate it outside of your body or reduce it to non-toxic substances. And compared to Huntington's, it's mostly characterized by wing beating tremors. So, as the name suggests, wing beating, wings. So, the patient usually has sustained abduction of the arms and like flexion of the elbows. It's like it kind of forms like a wing. So, the primary difference between these two is that this is like affectation. That's why I emphasize this word of the basal ganglia, while this is just copper accumulation. But again, they both present with movement disorders. So Parkinson's not really characterized by chorea nor wing beating. It's mostly resting tremors and rigidity. Next here, we have Parkinson mimics. So progressive supranuclear palsy is one of the most common neurodegenerative disorder that is initially thought to be Parkinson's. I'm just stating these information because usually it's pretty not really clear, but like you could focus more on the diagnostic criteria to really rule out Parkinson's or to really diagnose Parkinson's. Again, we have multi-system atrophy. It's an impairment of the cerebellum rather than the substantia nigra. And for MRI findings, so we could further differentiate here. So in Merritt's Book of Neurology, they mentioned this specifically. So the hummingbird sign. So this is detected in a midline sagittal MRI view, and it actually looks like a hummingbird. I'm going to show you the next slide here. So here is usually the uh, normal presentation of the brainstem. right? But in the hummingbird, you can see that there's a bit of a increase on pressure towards the brainstem. See here. So that's why it's called a hummingbird, because it kind of looks like the beak of a hummingbird. Yeah. So usually these are the MRI findings that are associated with these two and not with Parkinson's. And then you also have the hot cross bun sign, which is specifically more for the multi-system atrophy. And this just refers to the generation of specific nerve fibers in the brainstem. So this is a superior MRI. You can see here, there's not much pigmentation, but here you could clearly see the hot cross bun. It looks like bread, right? That's why it's called hot cross bun. So why am I going over these so fast? Oh, sorry. The reason is I would I would suggest that this is the more important information that you memorize, because these other diseases are, if we go too deep into it, it would be a very long discussion, and we're primarily focusing on Parkinson's. So yeah, but these are just the most common ones that can mimic or can be differentiated from Parkinson's. So yeah, and that's it for differential diagnosis. And goodbye. Next lecture is gonna be big.